Okay, I'm gonna keep going. Let me text Dr. Essence and just see. Okay. All right. I'm going to keep going. All right. So some of those sexually transmitted infections that exist, those that are curable, genital chlamydia, gonorrhea, urethritis, syphilis, trichomoniasis. We'll talk about several of those today. Then you have those non-curable or treatable but non-curable STIs, which HIV/AIDS, genital herpes, and then vaccine preventable are genital warts, hepatitis B. So when we're talking about chlamydia trachomatis, it's essentially a parasite with properties similar to those of viruses and bacteria. Typically, not typically, but 60% of the time, those patients who have gonorrhea also have chlamydia associated with it. It's a major cause of pelvic inflammatory disease. So this is one of those, if left untreated, can lead to infertility or ectopic pregnancies. So this, in a lot of times what we see with sexual transmitted infections, particularly in women, is they may not have symptoms, or it can incubate for quite a while, and they don't know that they are infected, and that's how it's passed on. That's how it lingers in the system. That's how it leads to more severe issues that we may see. Gonorrhea may be symptomatic, and we'll just talk in generalizations. We're not going to go too much in depth on the STIs, but I'm going to expose you to them. With gonorrhea, it can be symptomatic or asymptomatic. Again, a lot of the issues that as to why it can lead to infertility issues because it may be left untreated for a prolonged period of time, can be complicated or uncomplicated, and have infections involving several anatomic sites. Okay. Let me just make sure, I'm sorry, Dr. Estes had responded back, so I just want to make sure it's being recorded. Yeah, okay. Somebody's it is being recorded. Very good. All right, so I'll keep going. All right, so the clinical presentation is going to look different from males than it is females. So with males, you see urethritis is most common. You're going to have painful urination. Urination frequency is seen initially. So that's one of those things that may be seen. Complications can expand. Epididymitis, prostatitis, inguinal lymphadenopathy, and urethral strictures. So within their genital area, there are going to be some different symptoms that they will see. Typically, urethritis is the most common, and this will be something that develops within 2 to 8 days of exposure. So of them being exposed to someone during sexual intercourse. Females, cervicitis is the most common infection on the female side. Anterior spread of infected vaginal secretions produces urethritis. With females, it typically takes a little longer, and they will appear within 10 days of it. Again, painful urination is something that's going to be seen. Urinary frequency is going to be a symptom that's seen. Abnormal vaginal discharge, as well as abnormal uterine bleeding. Most infections are asymptomatic or have minimal symptoms. So these are just different symptoms that may be seen associated. So what does urethritis in men look like? And so typically, as I mentioned, with males, that's on the gonorrhea side, that is a common symptom, something that you're going to see associated with gonorrhea. And so what does that look like? Diagnosis is, and so we talked about dysuria, but diagnosis may be based on some type of discharge that's seen, and then a gram stain of urethral secretions that will be seen as well. That's what they're going to test. In those patients who appear with urethritis, because that is a symptom that's seen in gonorrhea, Men are typically going to be tested for that, as well as it's something that can be seen in chlamydia, because remember I said that 60% of those people who have gonorrhea also have chlamydia. So testing for both of those. Syphilis is caused by Treponema pallidum, and so there's different types of infections: primary infection, secondary infection, or tertiary infection. And so with syphilis, this is where there's going to be a canker or an ulcer in the genital area. And secondary infection, there may be a skin rash that's associated with it. There's also inflammation, or it can go to tertiary infection and infect other parts of the body that we have listed there. With syphilis, it can be a latent infection. And so it could be something that, with latent syphilis, maybe that person, even as far as back as a year ago, were exposed, and now it's just, showing up. And so it can be something that's just underlying. That's why it becomes important to counsel patients on using some type of protection to protect them from those sexually transmitted infections. Trichomoniasis. So with trichomoniasis, this is caused by Trichomonas vaginalis. Signs and symptoms, again, asymptomatic or symptomatic. Particularly when it comes to these vaginal infections, it's important to pay attention to the type of discharge, what it looks like. And so in trichomoniasis, there's going to be a yellow to greenish color. You pay attention to what is the color of the discharge, as well as what is the scent associated with the discharge in the vaginal area with these infections. So with trichomoniasis, it's going to be yellow to green in color, vaginal irritation, malodorous discharge. And so it's not going to be like a strong scent or anything like that, but it does exist. And so there's some type of discharge that's there, but it's not going to be a strong scent associated with the discharge when you are looking at trichomoniasis. Now, when we are looking at HPV, that's going to be a different one that you are going to, that's out there. And so with HPV, I'm sorry, I wanted to go back to trichomoniasis. I think I had mentioned that it's there. I think I mentioned that there was not a scent. There is a scent associated. Don't take that one as not having a scent. That does have a scent. It does have a malodorous, discharge. And so with that, that means it's going to have a strong and appropriate scent with trichomoniasis. So yellow to green color, yellow to green in color, as well as irritation with a strong scent associated with it. With HPV, that's going to be one of our common. And so in recent years, we've had I'm saying recent, within the past decade or so, there is a vaccine associated with HPV. And so that's come about because it's associated with cervical cancer. And so we want to be able to prevent that. So HPV is one of the most common sexually transmitted infections in the country, major cause of cervical cancer, as well as genital warts. With HPV, there are more than 120 types. However, there are common types that are associated with cervical cancer. And so types 16 and 18 are responsible for 70% of cervical cancers. So when we're thinking about the vaccines, that's what we are looking at. What exactly is it that they're attacking? What types are they attacking when we're talking about HPV? Types 6 and 11 are responsible for benign cervical cell changes, genital warts, and laryngeal papillomas. So it's important to recognize what types are responsible for cervical cancers, okay? So when we start talking about the vaccine, that's where this becomes critical, and what the vaccine covers, okay? So HPV, of course, the vaccine is going to work best prior to exposure, so it can prevent it, right? At this point, the Advisory Committee on Immunization Practices recommends adolescents 11 to 12 receive HPV, the vaccine. So there are multiple dose schedules that they can utilize. So there's a 2-dose schedule, and then there's a 3-dose schedule, depending on when they get their first dose. So at the for the 2-dose schedule, 0 between so they get their first, and then 6 to 12 months for adolescents up to 15 years. Okay, so at 0 months, that first dose, then in the next 6 to 12 months up to 15. So the 3-dose schedule is for those if they are older than 15, if they're just kind of starting the series. So then they take their first dose, 1 or 2 months, take a second dose, then at 6 months, take a third dose. But if they start before they are 15, they can do their first dose, and then at 6 and 12 months. Okay, so essentially you're looking at how old they are when they take the vaccine as to what schedule that they're going to be put on. So when we are talking about the vaccines, there are multiple vaccines, and they're going to hit up different types. So remember, we talked about HPV having more than 120 types. Type 16 and 18 are responsible for 70% of the cancers, cervical cancers that are out there. So one of the vaccines is Cervarix. Cervarix is bivalent, and it hits up the type 16 and 18. Now, we also talked about subtype 6 and 11. And so those are also responsible for benign cervical cell changes, as well as genital warts and laryngeal papillomas. So Gardasil, which is one of the ones that we hear quite a bit about, is a quadrivalent vaccine, whereas it hits up 4 different types. So it hits up the 6, 11, 16, and 18. It's going to attack all 4 of those. Then you have Gardasil 9, which attacks 9 different subtypes, okay? We can really talk about those other types, but the idea is to be as encompassing as possible. And so it's indicated for females and males 9 to 26 years old to prevent cervical, vaginal, vulvar, and anal cancers. So Gardasil 9 is going to have even greater coverage, okay? Gardasil, the one that you typically will hear about, the quadrivalent, is going to attack those 4 subtypes that are responsible for the most common cervical cancer types. Okay, so then hepatitis B vaccine. Hepatitis B is a virus transmitted through blood and other body fluids, associated with long-term complications associated with hepatitis, cirrhosis, hepatic carcinoma, as well as death. 79% of infections occur in individuals with high-risk behaviors or drug use. Vaccine is inactivated, injectable with schedule of 0, 1, and 6 months. So it's 3 doses. Recommended as routine vaccines starting at birth. So this one people get very early on. But as we kind of step away from this, I just want you to talk about trichomoniasis. We'll do a little bit more talking on some, but trichomoniasis, what I want you to walk away with, remembering that yellow to green in color with a strong odor. HPV, understanding the different types of the subtypes, what they cause, what the vaccines treat, what it is that they are attacking, whether they are bivalent, quadrivalent, nonvalent, what's the difference in those. And then with hepatitis B vaccine, recognizing that it is a 3-month schedule, and it starts at birth. Whereas with HPV, you're going to start at either under 15 years or over 15 years, depending on the age of the start. That's going to determine whether they're on a 2-dose or 3-dose schedule. Okay, so those are kind of the takeaways from there. All right, so let's move into pregnancy. Just basic intro on that. Results when a viable egg is available for fertilization by sperm. Contraception may occur during a 6-day window. So there's kind of this when you are fertile, when it's prime time for an egg to be fertilized and you are a female is ovulating. Generally, there is a 6-day window when pregnancy can occur. So it begins 5 days before ovulation through the day of ovulation. So when a female is ovulating, then she can, pregnancy can occur slightly before that. Okay, so And it can occur despite contraceptive use if the product is used incorrectly or if the product fails. Okay, so it's important that use is accurate, consistent, and it is being used how it should be. All right. So with contraception, there are non-prescription contraceptive products, as well as fertility. There are prescription products, which we don't talk about in this class. We talk about more so when you get into endocrine pharmacotherapy. But for the purposes of this class, contraception, we'll talk about those over-the-counter contraceptive products, as well as those fertility awareness-based methods. So whether it's the calendar method or what have you. But essentially, when you're not really focused on prevention of STIs, but more so prevention of pregnancy. So we'll talk about those as well. So when you are deciding which contraceptive method to go, or religious beliefs, like some people do not believe in using contraception in a traditional sense of purchasing a product. Additionally, so religious beliefs is something to take into consideration, future reproductive plans, product effectiveness, partner's preference, degree of interruption of spontaneity, ease of use, product accessibility, as well as cost. So these are all multiple factors when counseling patients that should be considered as which is the best route to go? What's the best recommendation to make for a patient? I'm going to pause. Are there any questions? I know I'm doing a lot of talking. Okay, I'll keep going. Okay. Yes. Okay. Somebody said.
I have a question.
Yes. I'm listening.
Yeah, we were talking about the gonorrhea. You said about 60% is affected. There's something you said 60% has it, and the next I did not really catch up what you said. All the people who have it, definitely somebody who has it, 60% will have the other side of it. I don't know what you're talking about.
No, I was saying 60% of patients who have gonorrhea also have chlamydia. Is that what you're talking about?
Yes.
Yeah, that's what I said. That
so they have what?
Chlamydia. Chlamydia. It was the other infection that we had talked about. Mm-hmm. No problem. Okay.
Thank you, ma'am. Thank you.
All right, let me go back to. All right, so back to infections. I'm sorry, prevention of pregnancy, I think. Yeah, so factors to consider when determining contraceptive method. We talked about that. Okay, so let's begin with male condoms. So male condoms are the most significant barrier to protect against STIs. So this, male condom is something that the male is going to wear, but this will allow for the most protection. They come in different types, different materials, and so depending on the materials will impact the type of protection that it comes with use of the product. So latex, polyurethane, polyisoprene, as well as lab cecum. So those are your different options. Proper use is essential to prevent pregnancy and STIs. Pre-lubricated can be a good choice when there's a need for lubrication, if that's a desire. Should be kept in sealed packages until time of use. Should be protected from light and excessive heat. Those things can decrease their integrity. Shelf life is 3 to 5 years with the expiration date on the package. So it's important for patients to pay attention to expiration dates. The Noxinol 9 coated condoms are no more effective than untreated in preventing STIs and no evidence in pregnancy. Okay, so it doesn't matter essentially about preventing STIs, if whether it's the naloxone 9 or not. And so where there's discussion about naloxone 9 and preventing pregnancy, so on and so forth, there hasn't really been the studies to demonstrate the great impact that some may talk about. Most frequent complaint is decreased sensitivity on the penis. And if latex allergy, may see contact dermatitis in male or female partner when using a latex condom. So it's important to understand sensitivities for the male as well as the female when utilizing condoms to help identify which one is the best type to use. So what are some of those things that increase the risk of condom breakage? Of course, incorrect placement, use of an oil-based lubricant with latex condoms, which really need water-based lubricants. Reuse of condoms is inappropriate. Increased duration or infrequent or intensity or frequency of coitus. So what type of activity are the people involved in? History of breakage or slippage. So it may, again, be user error in how it's being utilized. History of STIs may put people at risk of condom breakage if there are some issues with how it's being utilized, contact with sharp objects, or reported problems with fit, so not having the right size condom. So let's talk about the different types of condoms that are available, as well as what it is that should be aware of when using the condoms. So latex is going to be one of your most common. There is evidence that they help protect. Yes, somebody said something. Okay, maybe not. Okay. They do help with STIs. And that's going to be your most common condom that you're familiar with. And it's one of your cheaper condoms. But again, it is your most common. It is degraded by oil-based lubricants. So being aware if a lubricant is being utilized, whether it's oil-based or water-based. They come in various sizes, colors, styles, shapes, thickness, a variety. And so because like I said, they're the most common, they're going to be your cheapest. You're going to see the most variety associated with these. Other features associated with a condom, the latex condom, reservoir tips, ribs, studs, spermicide, naloxone 9, lubricant, so on and so forth, all right? So you see the cost of those. Then you have polyurethane, which are going to conduct heat well. So for some where they want to feel a little heat or feel something from their partner, polyurethane may be a better option. They are not degraded by oil-based lubricants. But remember, I said that the latex are degraded by oil-based lubricants. And they are available pre-lubricated. So latex, polyurethane. Then we'll move on to polyisoprene, more elastic than polyurethane. They can be damaged by oil-based products. So again, recognizing which ones can be, do you use oil-based or water-based with the condom? It's important to recognize that. Lab cecum, labeled only for pregnancy prevention, not necessarily to prevent STIs. So pores in membrane may allow passage of viral organisms. So it's important to recognize them. They are known to conduct heat well as well, very strong, not degraded by oil-based lubricants. So I want you to go back and be able to identify which one. So lab secant, not degraded by oil-based. Polyisoprene can be damaged by oil-based. Then we go to latex, degraded by oil-based, and polyurethane, not degraded by oil-based, right? So those polys, I will say, just kind of know the difference of which ones that you can use or which ones that you can't, as far as when you're looking at lubricants. Now, lab cecum, that's going to be your most expensive as well. It's also going to be the one I'm just highlighting, most expensive, and not necessarily significant protection against STIs, more so pregnancy. Okay, so female condoms, which out there, but not as common, right? Just kind of got introduced and, really utilized. And recent 20 years, I'll say, past 20 years or so, but consists of an outer ring, a sheath or pouch that fits over the vaginal mucosa, and an inner ring that secures sheath. Breakage rate is lower than that of a male condom. Now, vaginal spermicides, and so basically they are going to kill the sperm, as they say. Spermicides, surface active agents to immobilize and kill sperm. So when you are using gels and foams, the spermicide acts as a barrier against sperm. So that is the role. Effective spermicides include enoxaparin 9. That's one that you're going to hear about. Very common. Octoxanol 9 and Mempagol. So in U.S., all spermicides are going to have enoxaparin 9. So that's the most common. Used alone, they have a relatively high failure rate. So that is not the role for it to just be a gel or a foam. And I'm using the spermicide, and that's going to prevent pregnancy. Certainly not going to prevent STI. If it's just used alone. So it is designed to be used with a product. Naloxone 9 has been shown to inactivate many STI pathogens in vitro, but not recommended for use as such. So it's not necessarily approved for protection against STIs. And so that's where you see the notification that the product must say not to protect against HIV and other STIs. So although it may have some activity, is not marketed as such, is not approved for such. So it should not be, counseled as such. And in this case, when, for women, they should delay douching or what have you for at least 6 hours after intercourse when utilizing these products. And then, because again, you might clean out some of your good flora that's protecting you from any STIs when doing that, using those products. When used in combination with condoms, efficacy rate is similar to oral contraceptives and intrauterine contraceptives, which basically are about 99%. So that's why it is having a 99% effective rate. So when it says don't necessarily use alone, using it alone definitely decreases effective rate. But when used in combination, particularly with a condom, then the effectiveness rate is going to drastically increase. Okay, so vaginal spermicides, they provide additional lubricants. So with the vaginal spermicides, you're going to have it in a gel form or a foam form. Gels are safe to use with latex condoms. Applicators may be pre-filled before use, and you can use it as such. With foams, they typically distribute a little bit more evenly, adhere better to the cervical area and vaginal walls, provide less lubrication, however, than gels. So again, this comes down to preference. And let's see here. Just a moment. Solid, okay, so with suppositories, solid or semi-solid dosage form activated by moisture in the vaginal tract. Suppositories do not require refrigeration, but may be desired to prevent softening. So that's something that sometimes it, if it's kept in a space and it too long, warm space, be careful because it could melt, if you will, or soften and make it a little bit more harder to distribute evenly when being inserted. So it's different ways that the spermicides will come, whether it's in a gel, foam, or suppository, but a lot of it, again, comes down to preference. Okay, so contraceptive sponge. So this is something that this was out, then it left, and then it came back, taken off the market, but it's a sponge essentially that acts as a contraceptive and a barrier. It's a barrier, and as being a barrier within the cervix, inserted in the vaginal area, that is going to absorb semen. That's how it's designed. Made of polyurethane permeated with enoxaparin 9, a spermicide. So it's been marketed as Today's Sponge for $5 to $8 per sponge. However, does not protect against STIs. So again, it's more about prevention of pregnancy. Study found increased risk for HIV with frequent use. So this is one of those. It's very careful. Be careful about using. Must be able to locate the cervix to place sponge correctly. So it's important that how this is placed is inserted. It's accurate in how it's being utilized. Insert up to 24 hours before intercourse. So it could be, inserted very early. And again, this goes back to what's the most non-invasive way to allow for spontaneity when people are considering what it is that they want to use. Must remain in place 6 hours after intercourse, not to exceed 30. So this becomes a concern with the sponge, whereas the female has to remember when to take it out, what time they insert it, when did they take it out, because there can be an increased risk for toxic shock syndrome if it's left in there too long. Should be stored in an unopened package in a cool place and used before expiration date. Okay, so emergency contraception. So when we're talking about emergency contraception, this is something that's utilized after unprotected sex has occurred and within 72 hours. Pretty much people use this if there has been some other failure of contraception, whatever method has been used, whether it's, if they were on an oral contraceptive, they used that and they missed it. The type of contraceptive that they use, if they had condom breakage, whatever it may be, there are different moments where people, will use it, whatever triggers the use of it. Essentially, they had some type of failed contraception use. And again, we're talking about being aware of when ovulation occurs and when implantation can occur. So again, ovulation or implantation can occur anytime in that, days before ovulation. So there's a window of time. And so if a female feels like she is at risk, this is an appropriate option that she can take to try to prevent implantation. But once implantation occurs, the window has been missed, okay? So there's a period of time where female kind of needs to recognize where she is in her menstrual cycle and when ovulation will occur, because ovulation occurs mid-cycle. So if you have a 28-day cycle, within that day 14, 15, right in there, that's when your ovulation period is going to happen. So have to be aware of what the menstrual cycle is for that female and when ovulation is typically going to occur, and going back that 5 to 6 days to be able to say this is when it can occur. Because once implantation happens, it doesn't matter, then you've now missed the window. So what are the options for emergency contraception? It is over the counter. At this point, you take one pill, Plan B one step, next choice, or what have you. Of course, it's most effective within 24 hours. The closer to the time of intercourse, unprotected intercourse, or failed contraception, the better, right? Because once it happens, then, once implantation happens, then it's happened. So some side effects that may be experienced, sick stomach, nausea, vomiting, dizzy, so on and so forth. If vomited within 2 hours of taking the emergency contraception, you may consider repeating the dose. Menstrual cycle may not begin on time, just because this is hormonal, right? And so anytime you're making adjustments to the hormones, there may be some changes. So still want to go ahead and take a pregnancy test if there have been some changes in the cycle, because again, it's not 100% effective. If the menstrual cycle is more than 1 week late, there may be something worth looking into, because pregnancy may have occurred anyway. Okay, so I'm done with that part. Now I'm going to move into fertility awareness-based methods. And these are more so your non-traditional, non-product based, if you will, methods that are available as options. All right. So there's calendar method, cervical mucus method, symptothermal method, as well as lactational amenorrhea method. And so with those calendar, we'll talk more about your calendar methods and cervical mucus methods. We'll spend some time on those, okay, because those come a little different ways. So your calendar methods is focused on, factor in viabilities of ovum and sperm. Okay, so how long the sperm can survive, because it can hang around for up to 6 days. So being aware of when that fertility moments are. Cervical mucus methods is dealing with what are the changes in the mucus of the cervix. Okay, and so this really requires being attuned, a female being attuned to her body. In all of these, she has to be attuned to what's going on with her body. Symptothermal method combines cervical mucus tracking and basal body temperature. And then lactational amenorrhea method. This is not really something that we use much here in the U.S. It's more used in developing countries when trying to space childbirth, but basically while they're lactating and not having a menstrual cycle, how is it that they are, separating that period? So, all right, we're going to move on to calendar methods. So with the calendar rhythm method, this is one you kind of have to process it. But again, I mentioned a female being attuned to her body and recognizing how long her menstrual cycle is. Okay, when does her menstrual cycle occur? So calendar rhythm method uses this calculation method. So you calculate the first fertile day in the menstrual cycle. So the first fertile day is subtracting 18 from the number of days in her for this cycle. So this will require a female to monitor her cycle and be able to say, okay, maybe her cycle fluctuates. So is it 28 days, basically from the time of start of menses to the next time, so it's going to end, and then there's a period of time. Then when does it start again? That is how long the cycle is. So maybe it's 24 days. Maybe when she tracks, okay, this one was 26, this one was 30, this one was 24. So 24 would be her number. Subtract 18 from the number of days in her shortest cycle. And then calculates the last fertile day in menstrual cycle. So she's going to subtract 11 from the number of days in her longest cycle. So between those numbers, in between is the time that is not optimal, okay, that she should not be having sex. So looking at her first fertile day and her last fertile day. So trying to figure those out. So it's high risk. This is not a guaranteed method, but it is a method that's used, particularly if they do not want to use a product, use a hormonal or non-hormonal contraceptive. So they figure out their first day, first fertile day and their last fertile day, and the dates in between are the dates that they do not have sex. Okay, so you try to figure that out. My longest cycle was 30 days. My shortest cycle was 26 days. So based on my shortest cycle, I'm going to subtract 18. Based on my longest cycle, I'm going to subtract 11. And so whatever days those are in between, those are the days that I am most fertile. And I do not need to have sex if I don't want to get pregnant. That's how that method works. If a female has an irregular cycle, it's really not optimal because you don't know when ovulation is happening. Okay. So be aware of that. Standard days methods recommends for women with cycles between 26 to 32 days. So this is just kind of like a generality that should avoid intercourse on days 8 through 19 of menstrual cycles. So without doing that calendar rhythm of it being specific directly to you, there's this general standard, whereas just avoid intercourse days 8 through 19. But again, in any of these, it requires the female to be well aware of her menstrual cycle, when it occurs, when the first day was. Okay, and that first day is the first day of the menstrual cycle is the first day of bleeding, and so then from there you start counting. Okay, so avoid intercourse on those days 8 through 19. So cervical mucus method again also is going to require close monitoring and a female being in touch with what it is that her body is doing, what other what changes. So Billings ovulation, this is when a female has to pay attention to her cervical mucus daily, charts its character and quantity. So 5 to 6 days before ovulation, estrogen increase cause mucus to increase in quantity and elasticity and become clear. So again, remember we talked about those 6 days, it's their period of time. So this is my prime day of ovulation, but this period beforehand, there are changes that are happening, okay? And so due to an increase in estrogen within the cycle. And so there's gonna be an increase to the estrogen during that period. And so it's gonna be, the mucus is gonna become more clear. So again, being attuned to her body. Last day of clear mucus occurs within a day of ovulation for most women. For most women. Again, these are high-risk methods. There is no product associated with, there's no barrier. This is trusting your body. And so fertile from the first day after menstruation where mucus is detected until 4 days after peak symptoms. Okay, so again, high risk, but it roughly runs around the same time as that, we talked about the standard age, 8 to 19. But again, have to be attuned. So Billings ovulation method, again, 5 to 6 days, you're monitoring the elasticity of the mucus and how much of it is it, how much is it? And so again, fertile from that first day after menstruation where mucus is detected. So menstruation occurs, that's the bleeding. And so then once that stops, when do I see mucus? Okay, so when that mucus or discharge occurs in the vaginal area, when that comes, from that point until 4 days after the most has been seen, no sex during that period. Okay. All right. Then 2-day method, a woman monitors secretions daily. If she notes any secretions that day or the day before, she is likely to be fertile. If no secretions, she is unlikely to be fertile. So with these, essentially what it's saying, if there are secretions, if there is mucus, that's likely a fertile period, a fertile point, fertile time. So don't have sex. That's essentially what the cervical mucus methods, but it's giving you precise ways to measure that. But she has to be paying attention. Then there is symptothermal method. And so this is going to combine cervical mucus tracking that we just mentioned, between the Billings ovulation and the 2-day method, and basal body temperature monitoring. So cervical mucus is used to identify the onset of the fertile period. And then the basal body temperature is used to identify the end of the fertile period. Okay, so it's a combination, again, monitoring the changes in the body. So chart body temperature every morning before getting out of bed and at the same time after at least 3 hours of uninterrupted sleep. So if you're one of those people who sleep through the night, you had a good straight 3 hours, what's my temperature at that point? Onset of ovulation is detected by a drop in basal body temperature 12 to 24 hours before ovulation. So as you can see with these, there are a lot of standards that have to be in place, consistencies that have to exist in order for this to work. The body has to be consistent in how it does, being able to sleep on time and sleep for a long period of time, wake up, what's my temperature? Let's see, all right? The safe period begins once there has been 3 consecutive days of rising temperature that lasts until the end of menses. So that's the symptothermal. And lastly, coitus interruptus, or the withdrawal method. So coital activity so essentially having sex and the pull-out method, for the lack of better words, the non-scientific followed by withdrawal and ejaculation away from the vagina. But of course, this is high risk again because disadvantages require self-control by the man, potential for diminished pleasure by the couple, no STI protection. So if we're thinking about STIs, these are not your routes because this is not protecting against any sexually transmitted infection. This is simply about preventing pregnancy. But particularly with these non-barrier methods, your calendar method or, your symptothermal method, monitoring these, your cervical mucus, they're definitely high risk. So being aware, it is critical for the female to be well aware of her body and her changing body temperatures, her body overall, her menstrual cycle in particular, vaginal changes, cervical changes, be well aware of that in order to utilize these methods, and even still is high risk. Okay, so we're going to move to our last topic, which is badge. Any questions about that? Okay, so vaginal and vulvovaginal disorders. So remember when I had talked about trichomoniasis, I had mentioned the importance of knowing if there's an odor, and this is it's in the STI category, right? And so I talked about, is there odor? And what color is the discharge? And so with trichomoniasis, there was a strong odor and it's yellow and green color, right? So we're gonna talk about more vaginal infections. And so one of the most common is vulvovaginal candidiasis, okay, VVC. Candida albicans, second most common vaginal infection. This is one of those where 50% of women by the age 25 have at least one episode. 75% of women will experience at least one in their lifetime. 45% report at least two episodes. So it's very common. It is something that is seen, but it is treatable over the counter. Risk factors: pregnancy, uncontrolled diabetes, mellitus, estrogen-containing oral contraceptives, broad-spectrum antibiotics that clean out so-called good bacteria, condoms, cytotoxic agents, corticosteroids, immunocompromised patients, stress, diet rich in sugar. So a lot of different causes or common things that can exist. So it most people at some point in their life will be impacted by it. Signs and symptoms: thick white vaginal discharge, like cottage cheese. So there's a thick discharge associated, but it is odorless. Okay, so odorless, thick white vaginal discharge. Vaginal erythema, dysuria, we heard that before, like painful urination, vaginal pruritus, so some itching. Dyspareunia, which is painful sexual intercourse. So there are different things that will be seen with this, but probably the most significant will be that vaginal discharge that is not like a normal cervical discharge, mucus discharge that we talked about earlier, that's kind of thin, clear, elastic, that comes normal as a normal part of, female reproductive cycle. This is separate from that. It's a thick white vaginal discharge, cottage cheese-like, and odorless. Treatment: vaginal symptoms are infrequent, and so essentially it can be treated. Self-treatment typically is something that you are going to see that would be over the counter if you were using something. I think I'm getting ahead of myself, but with midazoles. But nevertheless, I'll just give you a little bit more vaginal symptoms. So when do you treat, right? At least one episode diagnosed, so you can treat it. If you have it infrequently, it's okay to self-treat, essentially. Less than 3 per year, but none within the last 2 months. So if somebody who had, I think I have candidiasis, but I have it right now, it's February, and I just had an infection in January, then they need to go see the doctor because it might be more going on. But if this is something that, maybe 6 months ago they experienced, and now here they are again, they can still go ahead and self-treat. But when it becomes more frequent, then they need to go see a physician. Refer to physician if it is first episode, 2 episodes, and past 2 to 6 months. If they're pregnant, younger than 12 years old or older, currently have abdominal bleeding, has been exposed to STD, have a malodorous discharge. So if there's a strong odor associated with it. All right. So again, frequent, they need to go see. You shouldn't just be having them regularly. Non-pharmacologic therapy, there are some people use yogurt to kill that bacteria, lactobacillus tabs, decrease consumption of sucrose, so gentian violet. These are over-the-counter things that are seen. Then pharmacologic therapy, that is over-the-counter. This is where you're going to see the imidazoles, the over-the-counter products that someone can go get. So butaconazole is typically 3-day, clotracomazole, 7-day or 3-day, miconazole, 3-day or 7-day, and then teoconazole. It's going to be a 1-day treatment. So these are those things that are available over the counter that can be utilized. And there are prescription-only products as well, but we'll focus on the non-prescription. All right, so what are some adverse effects of imidazoles? Vulvovaginal burning, itching, irritation, abdominal cramps, penile irritation. So typically when a female is being treated, they're not really having sex. And those creams are there, so you want it to do the treatment that it needs to do during that period of time. But if sex does occur, there can be some irritation, penile irritation during that period. For a patient who is using it, this is something that typically is going to be some type of suppository that they are inserting. And they insert it at bedtime, use a sanitary napkin, sanitary pad to minimize any leakage, to help with leakage that will likely occur. Expect symptom relief within 24 to 48 hours. They can be used during menstrual cycle, and when they're on their period, they can utilize it. Avoid tampon use or douching during that time. May cause burning or irritation. Refrain from intercourse during treatment. Again, it can cause some irritation. If the symptoms do not improve within 3 days, then you may want to talk to your physician, but they should. So when we are differentiating, again, between those various vaginal infections, there is bacterial vaginosis, trichomonas vaginitis, or trichomoniasis that we talked about earlier. And let's recognize the differences in those. So I mentioned trichomoniasis when we talked about it earlier, but I'm just revisiting in here to go back through and help you recognize differences. So remember with candidiasis, what we said was thick white discharge, and what else did we say? Y'all remember? I remember. I just want to see what y'all taking away. Was it an odor or no odor?
No.
No odor, right? No odor with candidiasis. However, when we are talking about trichomoniasis, is there an odor? Yes or no?
Yes.
Yes, and there is a discharge associated with trichomonas. And what does that discharge look like? What color is it?
Yellowish to green.
Okay, very good, very good. Now, with BV, or bacterial vaginosis, there's a vaginal discharge. It can be white to gray in color, but there's a fishy odor associated with it. Okay. Now, trichomoniasis has a strong odor, but it's not necessarily a fishy odor. Bacterial vaginosis has a fishy odor, and it's white to gray in color, the discharge that exists. Whereas with candidiasis, it's a thick white discharge, cottage cheese-like, okay? So with BV and trichomoniasis, with both of those, they require prescriptions. Candida is the only one that can be treated over the counter. And so that's the one where you use an imidazole. So clear, white, no strong odor, okay, we can treat that over the counter, right? However, when there is like an odor that's coming along with it, when there's an odor and a color, prescription. All right, so that's kind of a way when counseling patients to think about it. Okay, if it's thick, curd-like, white, no strong odor, then, you can probably treat that over the counter. They have their itching. They talk about the different symptoms associated with it. They're coming in saying it's a strong odor, it's a discoloration or something along those lines, then likely they need a prescription. Okay, so that's just a way to think about it. Trichomoniasis, pretty much metronidazole is all that you can use. All right, bacterial vaginosis, there are various treatments over the counter, but we're not here to talk about, I'm not over the counter, prescription that are used. And so I'm trying not to go that deep into it, but I want you to be able to differentiate with your patients when they should be concerned or seek medical attention. Atrophic vaginitis, this is something that's typically seen in postmenopausal women. And so essentially there is some epithelial lining that is going to decrease, and this is secondary to the decrease in estrogen levels associated with menopause. They may experience decrease in vaginal lubrication. You're going to see these as patients go through menopause and that reduction in estrogen, there are going to be vaginal changes. So the vaginal epithelial lining is going to decrease, lubrication is going to decrease, painful sexual intercourse will happen, it's a dryness. So all of those things associated with that is going to occur because there is changes in the epithelial. That decrease in estrogen is going to cause these different issues. So when working with the patient, you want to help them work through it. Now sometimes with atopic vaginitis, prescription-wise, there is topical, so it might be like a Premarin that they use, but that's not usually first line of therapy. But if they want help associated with it to help with it, then they can use vaginal lubricants. And so when you're talking to the patient, you want to determine what it is that they want to do. What is it that's causing it? Is this something that's caused due to breastfeeding? Because these are changes that you see when a female delivers and she's breastfeeding. So it might be short-term in nature, or is this something because it's menopause, it might be more long-term in nature. So helping identify what type of assistance the patient is looking for. And so if they are looking for something that's over the counter, there are water-soluble products. So those so remember, when we're talking about lubricants, we kind of talked about with condoms, is it oil-based? Is it vaginal, water-based? What type of lubricant can be utilized? So being aware of those. So these are some of those water-soluble lubricants that can be utilized with some of those condoms that we mentioned would be irritated by an oil-based. So Astroglide or KY jelly or Replens. So they are going to temporarily moisten vaginal tissues, provide that short-term improvement, burning and itching that may be existing. Petroleum jelly should not be used. That is not a best lubricant. Recommend one of these lubricants that are available. Only water-soluble products should be used with latex condoms and the diaphragm, as I mentioned before. And it can be used internally as well as externally. Okay. Oh, we got through all of it. Very good. So do you all have any questions for me? I know it's a lot of information, but I highlighted some things that I want you to go back and look at, kind of try to ask you questions along the way or re-emphasize some pieces. But with that, do you have any questions, concerns? Okay. Well, based on that, I guess we are done this morning.
Information based or going to be in a case study format?
if it is a case study, it might be like basic case study, you know, not password for attendance. Oh, let me see if I got that. Hold on. Somebody asked about it. Give me just a second. Yeah, it both. Okay, but a case study is not going to be like a full blown, you know, case study. It might be like patient walks in and they need advice on this. What do you recommend? And they were experiencing this sign or symptom. What do you recommend? Like it'll be very simplified, like a question. Hold on, let me see. Somebody asked about a password for attendance. Did I miss that? Give me just a second to pull that up to make sure I didn't miss something. Okay. Hold on. Thanks so much. I don't want to be, I want to try to get y'all credit. So. Answer. Hold on just a minute. I know y'all not going to. Right. Okay, y'all on top of it. Very good. So your password is the student line. Okay, is day 3, DAY3 Moultery 03. Okay, I guess I'll type that in. They have 1 minute to complete. Students log into Blackboard, go to quizzes. Oh, okay, that's fancy. I might have to try that. Okay, let me see here. I'll put it in. Yeah. Okay, that's your password. The team is tapping. Okay, so anything else? Okay, well, you all have a good day. Stay warm. Okay, bye-bye.
Dr. Moultry, do you have to stop the recording?
I don't know. I don't have
some issues this week with this. I just wanted to double check so that we don't lose it.
I don't, you know what? I don't have access because I think I'm in as like a participant.
Oh.
So